Hello everyone, I'm Abeda Mulla and I work as part of the strategy unit. I'm leading on the qualitative evaluation methodologies that we use here. But there's a wide team of people who do lots of the work here. So I'm pleased to see there's a good range of experience within qualitative methodologies, and nobody's outed themselves as a 10, because if you had, you would have been taking over from me in running this session. So nobody's owned up to that. So I guess I'll have to proceed. I'll end the poll. Okay, right. So today's session, we are going to run so we've got an hour, as Alicia's already mentioned, and I'm going to give you a little bit of the strategy unit experience with using qualitative methodologies, applying them. I'm going to start off with a little bit around the need. Why do we need to use qualitative methodologies? Moving on to when we use them. And then a little bit more focused around the methodology itself. How do you go about designing, some of the tools that we use here, and then the analysis and interpretation of that, and then going back and sharing that with the client stakeholders themselves. So as Alicia's already mentioned, if there's any questions that are coming up for you as I'm talking through, please feel free to put them in the chat box. We'll look at them periodically, and there will be some questions I'll be asking that you'll be using the chat box for. If I don't cover your question throughout in the process of delivering the webinar today, what we'll do is at the end just have a little pickup in terms of this, and then we might follow up if there's further kind of specialized detail that was required by anyone. Okay, so need. As you know, the strategy unit is part of the NHS, and we operate in this world where we're at the intersection between academia and also consultancy. So in terms of academia, there's the academic methodologies, academic research is concerned with getting the method right, making sure that the answers that you get from that method kind of correspond. And it's the domain of the universities, it's also the domain of think tanks. But then in the other side, we have management consultancies, and you'll be aware that management consultancies want to get the answer quickly. It's more about being practical about what's available at the time of doing it and making sure it's timely. So we operate in this field, in the intersection, where we also need it to be rapid and relevant, just as the management consultancies do. But increasingly, we also want to be rigorous. So we want to make sure that our the analysis that we produce, the types of work that we do, are have a transparency around them, have a method behind what we do. And you'll be aware that there's differences in terms of between research and evaluation. So what we do here is evaluation, and what evaluation is that it determines the effectiveness of different models that are being used. So it's different from research, where the purpose is to test a theory, a hypothesis, and wanting to produce findings that are generalizable. The evaluation questions usually come from the stakeholders. So it's usually a client asking us, look, we're putting a change process in place. We're going to do something different. We want to know whether it works. With research, the question usually comes from the researchers themselves. They know that there's a gap in knowledge, and they want to understand how that works in the real world. Evaluation, the quality is usually what we're increasingly doing is something called utilization focused research or evaluation, where actually the quality of the evaluation is judged by the people who are using this. So when the client comes to us and says, can you evaluate this service, and we do the evaluation, if they can't use the findings of that evaluation, then for us, is that really something that was worthwhile? Was that a good quality piece of work to do? So in link to that, the value of the piece of work is around whether it helps the program to be more effective, more impactful, and whether it can help to improve it as well. So there's kind of important distinctions between research and evaluation. When it comes down to qualitative research itself, so what I gave you an example of before when comparing research and evaluation was around generic research and evaluation. If we focus on the qualitative itself, it's a little bit difficult to define. You can get quite a few different descriptions of what qualitative evaluation is. I guess for me, it's sometimes easier to start off with what it's not. So it's not a measurement of quality. Because the name kind of sometimes, if you're unfamiliar, it implies that it's around quality, but it's not. It's around words, and it's again, it's not a collation of anecdotes. So it's not something that you would be you're just having these water cooler, the Americans call it the water cooler conversations. It's not around that. It's actually a systematic way of collecting data from people. So what qualitative analysis evaluation methods tries to do is provide an understanding of the social world. So it provides an in-depth and also there is a level of interpretation that's going on around people's social world, their experiences, their history, their perspectives on different things. In our healthcare world, it is around service experiences of services, experience of the healthcare system, and that could be from the level of the professional, but also from the level of the patient as well, of the service user. And I guess one of the main questions for people who are becoming familiar with qualitative and quantitative methodologies is, what's the comparison? Where, what are the differences between the two? So qualitative is more subjective. It's concerned with non-quantifiable data. And I think as an audience of mainly quantitative analysts, I probably don't have to tell you that the objective of quantitative analysis is to quantify data. And it's used to understand, quantitative data is used to understand how many times a phenomenon occurs. While qualitative is more around the why. So why does a phenomenon occur? Why is a patient experiencing a service as they are doing? Why can a GP not get patients to follow a service in the way that they would expect that to do? Why is the drug regimen not followed? So think the why questions are usually qualitative, the what questions are usually quantitative. In qualitative, the sample size can be quite small and can be non-representative. What you're trying to understand is a very rich understanding of an individual, a group of people's experience of something, whilst, as you know, with quantitative, there is a need, and the methodology might be dictated by the representativeness of the sample size, and it's usually, to make any kind of statistical inference, you want it to be large. And with quantitative data, you're testing, as we've mentioned earlier, you're testing the hypothesis, and you might then use that numerical data to even predict the future. With qualitative, it's around the social behaviors, the understanding of how people behave as a team together. So you might be able to predict, but you're basing it on social theories about how people work together or behave together. And it's often exploratory, whilst quantitative, you might be able to conclude on that. So with qualitative, it's always going to lead into further things. And if you take it out of context and apply it in a different place, you might get some new learnings as part of that as well. And qualitative methodologies stem from four main purposes. So you start off in terms of describing what the situation, what the social reality is, what are the kind of phenomena, the relationships, the processes playing together. So so if I give you an example of a project an evaluation that we're currently doing, which is a national program looking to deliver longitudinal health and care records. Some of you might already be familiar with them. So this is a national program that is funding 5 relatively large health economies, so wider than STPs, to innovate and take their local innovation in terms of a summary healthcare record across health and social care to see what effect that can have on the population. So it's a large program, as you would be aware. We're involved in the evaluation of the first stage of delivery, and the first stage of delivery involves a national program team delivering support. So what they've asked us to do in the first is work with these 5 sites, which are the case study sites, the wave 1 they call them, that are going to be delivering LICAs, and to describe what the national support program is offering. So the first stage is just around that description of the national support, the work streams within that. And then we're in the second phase, we're going to go and identify and explore how context, so how the local context of these LICA sites in these health economies, what that local context, so whether they have previous historical relationship, how mature the technology around the longitudinal health and care record is, what role does that play in the case in these sites to be able to then make use of the national support that's been provided to them to progress, to mature their LICA program itself. And through interviewing people who are actually using or benefiting from the LICA itself. So these could be service users, this could be the frontline clinicians. We can ask further the why and how questions, how they're interacting. So we'll then get to a level of explaining how that summary healthcare record is being delivered and used. And the end result, the end output that the client is looking for is how can they gain the information that they need from this program, from the evaluation, to help them improve how the LICA support program will work for the rollout. So for wave 2, which is coming up in the next year, and wave 3, which will be in a couple of years' time across the whole country. So they'll make use, so we will use qualitative methodologies to help them describe, to identify, explore, to explain, and then further to evaluate and assess what they need to do for this particular program. And well, I wanted to point out that, as most of you will already know, qualitative methodology is just one component of what we do here in the strategy unit, but it has its place in providing decision-making support to our clients. So as I described earlier, what we aim to do is be rapid and to be relevant and rigorous in the way that we do things. So applied qualitative methodology sits very firmly in the center of all our methodologies, and with that, it's what we do is we take quantitative knowledge, so the analytical outputs that people like you would be producing, but also the evidence base. So we have a team of people who look at the evidence that's been produced as part of peer-reviewed literature, but also the grey literature, the think tanks, the outputs are produced by think tanks, and even kind of program documentation that might come from NHS England as well. And that usually sets the kind of the premise, the formation of the type of work that we do. So we take all of those knowledge bases are equally valuable, but we take all of these into account when we're working on projects together. And for those of you interested in the evidence base, my colleague Alison Turner will be delivering a webinar on this just before Christmas. Okay, before we're moving on to the next section in terms of when, but just a reminder that if there's any questions coming up, please put them in the chat box. Okay, so I kind of introduced this concept of utilization focused research and evaluation within what we do. And our main goal is that the outputs that we produce, whether it's qualitative, whether it's quantitative, whether it's the combination of the two, that they are used by the client. So what we increasingly say is this bit on the left-hand side, the action-orientated aspect of it, so that our findings, our recommendations are used in decision-making. They're used to improve the service, the system, whatever the focus of the evaluation is. That all of that is used. And increasingly what we do is when we design a project, when we're talking to the clients at the beginning of a project, we ask them, how are you going to use these findings, and how can we support you to do that? And then other colleagues, people like Karen Bradley, who are working within, I think is in the audience at the moment, people who are working within this field will then take it to the clients and say, well, you know, we're doing an evaluation around primary care. These are our findings. How can we work with you to improve your primary care offer? So it is increasingly about that. Where we get the breakdown between quantitative and qualitative, and I've already mentioned, quantitative is, you know, the what bit. What effect does this service change have? What effect does this intervention have? Qualitative, why does it have the effect? We take the knowledge of the two and take it back to the client. Quantitative, so what the other way that we usually break it down in terms of outcomes, because people are obviously, if you're putting a change process in place, you want to know what effect it has. Quantitative, we can map it to two of the quadruple aim, and this is something that we do quite frequently in terms of thinking about where does this hit in terms of quadruple aims. So those of you who are familiar, this quadruple aims looks at population level health outcomes, population level outcomes in terms of whether it's clinical outcomes or health outcomes for the population, also looks at cost effectiveness. But then there are two other components of the quadruple aims, and these very neatly fit into kind of qualitative methodologies, and those are about the patient experience, the population experience, and also about the staff experience. So most of what I'm going to talk about today will go into those two aspects. For those of you who might have attended the PHM Core Academy sessions last week in Birmingham, or your colleagues might have from your population health management teams, I had a bit of a light bulb moment, and Al Mully and Margaret Mully might be in the audience as well. And one of the sessions that they were delivering, and I was part of facilitating, that it was around engaging your population, your service users in change processes. And it made me reflect that actually, whilst a lot of what we do in the strategy unit is around the kind of more objective evaluation, there is no reason why those of you working in the field of frontline projects, that where even if you're doing quantitative projects, why you can't use some of the methodologies that we're going to be talking about here with respect to just at the beginning of a change process. So just involving people who are going to either deliver the change or receive the change, and why they can't be considered as part of the change process itself. And that itself has quite a precedent in kind of action research, and especially in service user involvement. So it's referred to as co-design, and in this little illustration, you can see it at the top. So at any point where you're thinking about introducing a change, where it looks like you can do a service redesign as part of that, involve the people who already have an expertise in that area, the frontline clinicians, the people who are service users. They can be the usual people, the people who are already identified themselves as expert users. That's fine, but as long as you get an understanding of what's required there. So if I take as an example one of the PHM projects. So last week I was listening into a conversation for Coventry and Warwickshire, where the PHM project is around diabetes. And in particular, it's around improving the service offer with a view to improving the outcomes for the diabetic population. But in this instance, it's around supporting the needs of those newly diagnosed. So at that point, so where this has been decided as because there's a population level data that this is a problem, that the population with diabetes need extra support. So at the level where that's been identified by system leaders, there is now a need to go and talk to those who are involved in the first diagnosis. So those would be your clinician, your GPs, your endocrinologists, to talk about actually what are the needs at the moment in your experience, in your expertise. What is the first needs? So talking to these people, applying some of the qualitative methodologies that we'll talk about is a really good first starting point. And then where possible, talking to some of those service users as well, saying, actually, you've just been diagnosed, what are your needs, what kind of level of support that's available. And then also going back into some type of program documentation to say what is actually available, talk to people who've already been running services for this already. So it's never a starting point from scratch. There is always some information, some expertise that's available to support that. So you've got that as the first process, the co-design bit, but then you can also go along and continue in that approach and co-produce. So what co-production means is that you're working with your same kind of your expert group, whether they're professionals or the public, to then say, okay, we've done the first stage of, we've done our data collection, we've delivered the service. How do we assess it? We've got a view to how we assess it. What do the findings actually mean? Because interpretation, as we'll talk about in a bit, is within qualitative studies is quite subjective, and so the more people, the more eyes, the more different experiences, the different frames of reference that you bring into those discussions once you've got those findings help provide a better value to the output that you produce as part of that. And then if you continue on in that kind of cycle of co-design and co-production, you are then in a position where actually the people who are either who need behavioral change or who are actually delivering the service are so entrenched in the findings themselves that they are able to action. So you're in a position where you can actually make the changes very quickly because the people whose responsibility it is to make the changes are doing it in a live way. So you can't control for what happens next, but this is the situation with complex interventions in any case, and part of it is that you want that action to happen. So some of you might be familiar with this already, but this is just a little bit of a cautionary tale in terms of when to do an evaluation. So we've got the thing, we've already talked about when to involve people, and it's always right to involve people when you're making a change. But when it comes to evaluation, timing is important. And some of you will be familiar with this, might have seen this before. It's called the Gartner hype cycle. And basically what it's suggesting is that there is a right time when you're doing, or you should know what your expectations of an evaluation, depending on the time of when you actually deliver the intervention and the evaluation. So if I take an example of an evaluation that we were commissioned to do, which was a mental health, urgent care, but mental health evaluation within a mental health trust. And they actually had a very, everything's always kind of labeled as innovative, but this was truly innovative intervention that they were putting into place, which relied on developing technology. So they were funded to develop the technology and at the same time deliver the evaluation. So at the time of commissioning, we were at this peak of inflated expectations. So everything was going to work, and the evaluation was going to show some very positive outcomes. And so this was at the point where we all went in and tried to do something. Now, as you will probably be already have experience of, that at the time when you're developing technology or you're developing an intervention, it takes a lot of time. So at the point where we had to evaluate, the technology wasn't ready. So we actually, in the end, evaluated something that was at that trough. There was a lot of disillusionment, but the money for the technology and the money for the evaluation ended at that point. the trust was then had to go it alone basically, and carried on doing working on what they were doing. And they are now about 18 months later, they are now at that slope of enlightenment. They are getting into a level where they're producing an output and things are working. So it's just being aware of actually the time that it takes, and managing expectations of evaluations. Okay, I'm going to stop talking and give it over to you. It's a little bit of a trick question, but can you think of occasions when applying qualitative methods may not be a good idea? You could put your answers in the chat box.
I think everyone's doing some thinking. So we've got one, if there's no people involved, evaluating cost savings, another option.
Okay, I did say it was a trick question. So the main thing is it's always a good idea to involve people in change and to get their perspectives on what's happening. So it's the bit that we talked about in terms of co-design and co-production, and that helps in making sense of what you found. So what a lot of what I'm going to talk about in terms of the methodologies are around kind of very objective evaluation, but you can always use some of those tools in trying to do when you're doing, whether it's small scale or whether it's something that you need to get going with quickly. So you can always use some of those things. When it comes to formal evaluation, if the program is really unstable, it's very unpredictable and there's no consistency, so you can't actually get in, when people can't give their time to be able to be interviewed, or if they won't give you complete access to their service, then you can't really get a good sense of what the program is. Then that's probably when you wouldn't.
Yeah, so Katie said here about what about when the resource support the evaluation is uncertain? Things that fits into.
Yeah, exactly. So resourcing. So what we would normally do, because with our qualitative evaluation, we can have very large in-depth evaluation, and some of the national ones that I talked about are like that. When it's a local one, they will have a budget, because that budget will be part of everything else that goes with their program. So an evaluation budget, and we will tend to work alongside that. And again, sometimes there's a call for mixed methods, so we'll work alongside our quantitative colleagues as well to be able to do that. So we can work within budget to be able to do that. For some of the stuff that you might do that is relatively small, you might think actually there's a budget to do some quantitative analysis, but there's not much budget to do qualitative. But then having a conversation with the people who are running the quants, just to make sure that your assumptions are clear. So at the very little, where sometimes we are informing our quantitative colleagues, what we tend to do is we might just talk to a few people just to check on their assumptions, or we might run a couple of focus groups to say, you need, for your modeling exercising, you need to understand how people are using a service. So for a particular hospital, actually, we've just done something very similar, where there's a quantitative modeling exercise going on around expected dates of discharge, but we needed to understand how those assessments were made in the different wards in this one particular hospital. So we went and did some focus groups with nurses across the different wards, and with doctors across the different wards, to see how they think about expected dates of discharge, and the information that we've gleaned from there, our colleagues are putting that into their modelling assumptions. So yes, budget concerns are a very real concern, but there are always ways of working around with. And if there is no budget, then I would still go back to that first bit and saying, just talk to a few people who are the experts in the area, just to understand what their assumptions are, to help that feed into your quant's assumptions. Okay. And so the other bit is, if you're doing a qualitative kind of assessment and you are not privy to detailed knowledge or any knowledge, or people are and not allowing you access to key individuals, then it's going to be difficult to really understand what's going on in that program. Okay, we're going to move on to designing qualitative studies, and a really important consideration in qualitative methodologies, especially at the more research end of it, is ethics. So talking to people, whether they're service users, whether they're professionals, still necessitates a kind of ethical approval or good practice. Now, most of what we do, we are not changing. We are not going in and saying we're doing a randomized control trial to see whether, you know, one group of people do receive a service and another doesn't. We don't tend to work that way within the NHS. What we tend to do is an evaluation of something that is going to happen because a need's been identified by the hospital trust, by the system. So and usually goes out to all the population. So there's no randomization. Anybody who are going to benefit from the service will be included in there. So we tend not. So our type of work is not classified as research and will then not require ethical approval. Having said that, the mental health intervention that I mentioned earlier, that the client had to go through a whole procedure for that. But the bit that we were doing did not necessarily, because we were interviewing patients at that stage, did it require that. So it's just something to be aware of, that most of what we do does not require ethical approval, but we follow good practice considerations. And what that means is that you are very transparent about what you're doing. So when we are recruiting to our evaluations, before we go out and talk to anyone, we produce what's called information sheets, participant information sheets. And this might not even be for patients, but it could be for any staff that we want to interview. We tell them what the project is. We tell them how much time we are going to need, whether that's going to be face-to-face or over the telephone. We tell them how their data is going to be stored, how their data is going to be used, and we give them the opportunity to have a conversation with us. And we do get followed up on that. So people will ask, well, why have you asked me? Usually the people are identified through whoever the client is who've commissioned that piece of work. So they'll say, these are the experts, we want you to talk to them, and we'll get their details that way. If we're doing patient interviews or we're involving the public, and then we keep it as plain language as possible, and the less details, but actually usually we do a phone call with them as well, just to make sure that they've understood what they're participating in. We follow a consent process. So a lot of what we do is interviewing, and those can be telephone interviews. And so when we're doing them, we will give them an active consent. We'll also, if we're going to people's houses, we might take a second person along with us, and maybe even ask them if they want someone else there. As far as possible, we provide anonymity. Sometimes it's not always possible. If there's a service that's being evaluated, if the ask is to talk to everybody in that service, if everybody represents a different organization, sometimes for people in the know, people will be able to tell who that person is. So we don't ever report on the individual, but sometimes that can happen. And then we might offer that we'll share a summary of their findings with them. Sometimes people ask for that. And then if there's anything that we pick up on, usually with patients, if we pick up that they might need additional support, we might then go back to their GP or something to be able to then say to them, I think this individual needs some other support service. So that might happen. Qualitative sampling. Just looking at the time. Okay, so qualitative sampling it's very different from quantitative sampling. So we're going for a sample size where, as we've said, it can be less than 10. What you're trying to do is get very in-depth data. So what we could do is something called purposive sampling, where, as I said in the other example, the sample has certain characteristics. They might all be part of an MDT. So you're interviewing all of them because they're part of that a team. Otherwise, for our Leica national evaluation that we're doing, we've followed something called convenience sampling, where people are asked, because of their role, will they participate, and of the ones that have said yes, we can then take a subsample. So it's just mainly about, are you available between these 2 weeks to talk about this service that you're providing. In other cases, it could be opportunistic, where you find someone is doing something as you're doing some other field work, and then you might ask them for an interview. And in other cases, we might have snowball sampling, where people who've already participated are asked to identify other people. I'm gonna skip over this one, but just to say that there's a different methodological stances that you might come from, and in terms of how you deliver this. So within qualitative methodology, the key thing is that you're quite flexible in design, in how you collect the data. You do want to have detailed analysis, though, so the burden, usually we try and flip it, so the burden of work is on the analysts, and how you engage with the data itself. You're quite clear about your stance there. Quickly, does anybody have any experience of going through the ethics process, and similarly of the information governance process as well? And what are your key reflections within part of that? Okay, so what I wanted to pick out there is just to be able to mention that both ethics, and I know from our quantitative people, when we follow kind of even IG processes for data, it takes time. So it's just about the just making sure that you've accounted for that when you're doing your projects, to make sure that there's enough sufficient time has been built at the beginning of the project to be able to do that. And you'll get more questions about it than actually is than applies, but it's good. We have a kind of a best practice approach, and that works well.
Someone said that they've used this at university.
Yeah. So as I said, most academic projects or research projects where the research need has come from the researchers themselves will have to go through some sort of ethical process.
And someone's got experience of going through REC?
Yeah, so so now it's the NRES, so the National Research Council. Yeah, so the qualitative study involving people living with dementia. It is time consuming, but you're right. It is really essential, and actually they make you go through questions at that point, which makes you really think through your design and make sure that it's very service user focused. And you're right, it's very helpful. Thank you for that. Okay, so I'm going to move on to the kind of tools that we use. So our qualitative methodology tools that we use here in the strategy unit. So we can start off with qualitative surveys, and we move on to, so as you move towards the right of this graph, it becomes more and more rich. But as you can see, what that means is that it becomes more and more resource intensive. So qualitative surveys are probably be the least burdensome in terms of both for the participant and also for the evaluator as well. So you do an online survey and people can fill it in at their own time. Then you've got something called document analysis, where you're looking through data that's already been generated. And then you can have focus groups and interviews. and then moving on to kind of ethnographic approaches, which are observations. And I'll talk about these in turn. So qualitative surveys, different from quantitative surveys, is that you're not counting the variation or distribution in a sample, but you're looking at the characteristics of diversity, so in terms of their perspective. So usually when we do qualitative surveys, we are doing them because we want to reach a bigger sample. You know, we want opinions, perspectives from people, more people than we can feasibly interview or do focus groups with. And we also don't need too much information, but we just want to have a quick understanding of you know, the perspectives on different aspects, kind of comprehensive aspects as well. So participation, as I said, is low, and you can do it via online methods. The disadvantage of that is that to get it to the right people is sometimes hard. We tend to work with the client to kind of to say, would you administer it, would you promote it via your own comms networks to be able to make sure that, you know, whether it's a diabetes population, whether it's a health and care population that are working within PCNs. So we'd ask them to do it their way. And also with surveys, you've got to be really careful. So piloting that survey, getting it right, because the questions can be ambiguous, especially when you're going out to a wider population in terms of the public as well. So you'd use it when you want a breadth of perspectives, you don't really need too much depth, and we tend to usually use it at the beginning of a kind of a more complex evaluation where we wanted to inform the next steps. Document analysis for us, we tend to, and what I would advise as well is when you're part of a quant evaluation, or you're part of doing quantitative assessments, actually going back and looking at previous program reports, anything that's been done in that area, any business cases. So for the diabetes one, looking at what services are provided for newly diagnosed patients, the feedback on those services, any kind of website information that's available for, you know, wider programs. Those things are really useful just to get an understanding of what's actually happening, what's happened previously, and how you can build on that as well. So that's what we tend to do, is when we start an evaluation, we'll ask for documents, any documents that the client thinks is relevant, and what we tend to get is a bit of a documentation dump. And so we'll quickly look through them to see, okay, which ones are useful, which one will help. And a lot of the times we're developing our kind of theory of change via that. So they are very helpful starting point. The mainstay of the work that we do, qualitative work we do, is interviewing, and I'll talk about focus groups in a bit, but focus groups are usually just group interviews. So what interviews allow us to do is get this exploration of the individual perspectives. So when something is being introduced, before it's been introduced, as it's being introduced, after it's being introduced, what was the individual's perspective? So this, in a multidisciplinary team, it's the experience of the general practitioner, it's the experience of the practice nurses, it's the experience of the health and the social worker. It could be, you know, lots of different, it could be the patient voice as well, could be part of all of that. So you're getting a really holistic view on what's happening, the experience around all of that. Disadvantage is sometimes, especially more for the senior level ones, there could be an agenda. People are want to say exactly, you know, there might be a level of the pre-rehearse in terms of what they want to see. On the other hand, there might be people who are very worried that they're being interviewed and don't really want to say very much. It could be time intensive, and also there's something around having a rapport between the interviewer and the interviewee. And what we tend to say, especially when you're doing it and borrowing qualitative methodologies for other purposes, we would say for an interviewer, go with someone who's got natural rapport with people who are good at facilitation in other situations, so who are able to have a good natural conversation rather than a person who's good at analysing the information. So you could divide that up and go with the people with the natural skills to be able to do that. So focus groups, as I said, they're essentially group interviews, but what happens there is that the interviewer becomes more of a facilitator rather than an interviewer. So you have your list of questions that you will develop and design, but what you will tend to do is make sure that everybody has an opportunity to talk, and so you would be taking those facilitator skills into play there. They can go more off track than you can in interviews, but that again, it's the skill of the facilitator to be able to go along. And you'd use it above doing individual interviews, because you want to look at the dynamics of the group. So for a project that Karen and I are working on, we want to understand how PCNs are progressing. So for that, it makes sense to have a focus group with representatives of the PCN to actually say, okay, what are the new dynamics between these individuals? Interview can take a few different forms. So it could be structured, semi-structured, loosely structured, and unstructured. We tend to be very much on the semi-structured guide aspect, where we have a number of questions that we know we want to ask the interviewee, but we will let them go off track a little bit, because sometimes you get better insights from letting them go off topic. So our professional interviews tend to be semi-structured, but when we're talking with patients, they tend to be very unstructured, very narrative, because sometimes it's the best way of getting a rapport with the patient. And actually, you don't want to tell, you want for them to talk about the experience in the best way that they want to, and then you do a lot of sense making after that to understand what's happened. But it does require more interviewer skill to do those narrative interviews. There are different approaches that you would take when you're interviewing service users than you would do with professionals. Some of it's just as simple as friendly language, and sometimes you would use visual interview tools. Audio and video diaries are becoming quite common. We've not used them here in the strategy unit, but I do have experience, and other colleagues have experience when they've used them in academia. But that's increasingly becoming more rapid. So people are just given those and they do their recordings themselves. So they're very much narrative in that case. One thing to note when you're dealing with the patients or the public is try and kind of find those voices that are not normally heard, and make sure that the sample is as representative. So if you're doing diabetes that affect, there's a high proportion prevalence in ethnic minorities, then maybe you target those groups a bit more than you would in other cases. I'll leave these for you to read, but there's flexible approaches to doing the interviews themselves. There's good practice, what we would do for professional interviews, but then there's ways of doing them to be flexible with that when you're interviewing users and carers. The other technique that we use is observations, and there's less call for them in our work. But having said that, there was a large evaluation that we did last year where we were looking at an urgent care system, and one of the things they asked us to do is observations, and the way we did that was we listened into their system resilience calls on a daily basis to understand how operational leads enacted urgent care delivery for this for a specific time period. But then we were also invited to their urgent care board meetings, where we were observing, so both as participants and non-participants, with regards to how they, as system leaders, delivered or demonstrated leadership within that period of time. So it's very labor intensive, but it does have its uses, and we were able to get some very rich data that is helping the client improve on their urgent care offer.
Abby, so someone's just got a question here about, can you say a little bit more about journey mapping techniques?
Okay, so journey mapping techniques would be something that would be as part of your narrative interviews. So for patients, so where we've used them, where we have experience of them is you would talk a patient through a service user through their experience of working with of experience of usually a chronic condition, and all the different pathways, that they use, they have experience of. So where I've seen it used quite successfully is they had almost visual tools. So they had a picture of the hospital organisation, their GP, the hospital, their GP, their social care support, and they were asked to draw lines in between them. So as they were talking through, they were just asked to draw lines in between how many times they were for a specific appointment, for a specific time period, how many times they would use that. So those are part of the kind of like the patient journey. So it's a visual way of service users demonstrating that. So you can use it either within that, or you can do it afterwards when you've got the data from a number of service users, and then you're developing this kind of almost it's not necessarily an ideal word, but the experience of service users for this particular pathway in a particular system. So you would maybe then draw it out as part of your outputs, or you might describe that as well in the form of words as well, depending on what the client wanted. Hope that helps. Okay, I'm probably going to skip this over to you methods. I'm just going to run through how you convert the data that you've collected, which is in the form of words, or as we've just talked about, video, audio details, how you turn that into data. So from observations, you'll have notes from audio and video recorded. You have transcripts from your document analysis. You'll have words. So you go through a method where you'll convert that all into, if they're not already in words, you'll convert that into words, and that is basically your qualitative data. If you can imagine, for a 1 hour interview, you have you can have up to 20 pages of written words. It's quite a lot of data that you have to manage. So the analytical process that we follow is called, we start off with something that's called coding, and I've used this kind of wool and thread visuals to illustrate the points that I'm going to make. So what you tend to do with all the word data, you've got lots of different strands of conversation, but lots of different strands of themes that you start unpicking that. So you have either the slide before, I was going to mention that there's two approaches to analysis. You have an inductive or a deductive. We tend to use a deductive approach. So you already have an idea of what your framework is, or what the main themes or what the main codes are. And so what we would do is code them. You literally copy and paste with the software that we use into those different things about it. So they could be as simple as leadership. It could be as leadership, how how people are serve leadership, teamwork. But then you might go into a level of subcoding where you're kind of saying, okay, what's the style of leadership? Is it around heroic leadership? Is it around system leadership? Is it about network leadership? So you'll start kind of understanding what that is and theming it as part of that. And then what you're trying to do across all your data, qualitative data, is that you're synthesizing, you're then providing new insights because you're doing a level of interpretation. So it is very time intensive, but we do have software, things that are available. In a very quick phase, where you're just doing feedback forms, you might have surveys. You could the essential thing is about rereading, and then asking a number of people to look at that same data after you've structured it, even if it's just using highlighter pens. After you've structured it, asking a number of people to look at it so that you've got objectivity, so you maintain objectivity. Some of that bias is removed.
So we've got a couple of questions, Abby,
yeah,
in the chat box. The first one was about what are your views on quantifying qualitative data?
Yep.
So particularly surveys.
Yeah. So for academic teams, quantifying is a no-no. If at the moment you decide to quantify, you're not doing qualitative evaluation anymore. What we tend to do is mixed methods. So you will take that quantitative data that's come from another source. You're doing it different things, and you'll take the qualitative data and you'll see what answer does that give you at the same time. In any case, the type of qualitative work that you will normally do, the N is so small that you would normally not be able to do any statistical inference on that at all. In survey methodologies, it's usually a mixed method, so where you kind of saying rate it, so on a Likert scale or something like that, you might then kind of say, this is where the percentage lies, but we increasingly ask for free text responses to those things as well, so that you build it up a little bit better. A question around free software. Unfortunately, none of the software is free. None of the good software is free. And the software that's available is quite good. We are now working with the one that we use is called NVivo 12, and it's very good. And we are, because we were one of the first in the NHS pioneering kind of use in this. We're getting to some deals. So we'll keep you posted on how that works out, but unfortunately none of the good software is freely available.
And the final question is just about the difference between inductive and deductive.
So inductive is where you start off inductive is where you basically in qualitative methodologies they talk about grounded theory. You have no assumption of where the data is going to take you. You observe, you do your observations first. It works really well with narrative interviews, your observations, and then you look for your patterns. With deductive, you have an understanding. You starting off. So in our world, it's mainly always deductive. You have a theory of change. You know why why the intervention is in place, why this program is happening. So you start off with that. Then we will do the observations, but simultaneously we know what main themes are going to come up into play. So for the longitudinal health and care records that I talked about very early on, we are applying an academic framework and doing deductive analysis. So some of you might be aware of someone called Professor Trish Kleenhag, who's done a lot of work on technology adoption in healthcare. So she's already done lots of work and come up with a framework. So we're using that as our deductive framework to test whether adoption of the Likert is according to this framework. But what we will do is have inductive themes within that. So as we're doing for this particular program, for this context, what can we find out that's new? So it starts off deductive, but we'll bring in a bit of inductive as part of that as well. Okay, and I'm just going to finish off with how so I've talked about qualitative methodologies. We've kind of answered some questions around how you quantify some of this, but essentially what we do in the strategy unit is triangulate the different sets of data, and this could be different qualitative methodologies. It could be with the evidence, it could be with the quantitative data as well, and that gives you a better understanding of the question, the kind of evaluation question you have. The process of combining is called triangulation, and it's usually done quite systematically. We build it in intentionally, and at the very least what we try and do is bring it all together at the end, and we might have an internal triangulation meeting where people who are not part of that evaluation necessarily, but have within the strategy unit, we might bring other opinions into play to say, actually, let's do this sense making. And what we're trying to do increasingly as well is get the stakeholder, the client, to kind of say, look, these are almost our kind of raw data, help us make sense of them. And what that facilitates is action. So the bit that we talked about earlier is if you're there present where you're doing the sense making, different light bulbs go off for different people, and you actually start bringing that into practice very quickly. And that's the strength of doing it this way. And this is one way. So where we do the triangulation is usually in the terms of case studies. So increasingly a large scale program is being rolled out in different areas, but how does it work in Worcestershire compared to how does it work in Shropshire? How does it work in Staffordshire? So if you're doing that kind of thing, you would normally take that data from all of those, the different types of data, and write them up as case studies. And what we know is that context really matters. So we try and kind of detail that out quite a lot. And then, as I think I've kind of already talked about this, but what's very, very important is how you take the findings. And previously, where people have asked us for our evaluation findings in a report or as slides or as a, come and tell us and present your slides to us. But what we try and do is kind of, and for those of you who were there when last week at the PHM, when we had Dudley's, the Black Country accountable officer, talking about the word that he mentioned was actionable insights. So what we try and do with our work is try and provide some of those insights so that they can be turned into recommendations. I think we've run out of time for these, for the kind of the quality bit about it, but it's just making sure that there is, even for if you're hardcore qualitative analyst, some of what I've said might feel really anecdotal, might feel too subjective, but it's just to let you know that there is a whole scientific discipline through all of this, and one of the things that we look at and the academia have got a very good handle on is about how you put quality within that qualitative process as well. So it's engaging with the work constantly, as asking about its relevance. It's asking about the way that your data collection is conducted, and also throughout the process, it's the evaluator, the team's role in interpretation and utilization. Any other questions?
So Mahmood's just put in the chat box about if anyone's interested in NVivo. They've got a free webinar on Wednesday the 4th of December, and there's a link there to, I believe, to sign up to that. So if you are interested in NVivo, please take a look at that.
Thanks, Mahmouda. Mahmouda is our kind of leads in the strategy unit on on using NVivo. So she's definitely the right person to answer that question. Thank you, Mahmouda.